So everybody is having exams next week and over next 2 weeks. So as we have shifted the gear this whole week, we know we did all practical cases. We did an early breast cancer, then we did a oral cancer, oral tongue cancer, and now we have a rectal. Next week, I have put an LABC, and only all teachers of MCH, DRNB, and examiners are your external examiner and teachers today as an expert. So utilize this opportunity best. We have the two most eminent, senior most professors, Dr. Chandramohan and Prasanth, who are extremely good teachers. Lot of students are getting taught by them both in the association of IASO as well as in the institution, and they both are great friends of me, and always in spite of the busy schedule they lend their time to teach, because they also believe like me that knowledge use is best put into use only when it is transferred to the students through. So in spite of all the difficulty, time, busy schedule, they really accepted. And all of you know Chandramohan and Prashant, they have been helping our student, great teachers, great academicians, more than that, excellent human beings. Thank you very much, Prashant, Chandramohan, for accepting it. And
So thank you for your kind words. It's always it's a habit of Somu to praise the examiner to such a level. I think the examination more tensed about the procedure than the students itself.
Thank you, sir.
Thank you, Somu.
Agree. Over to you, Narendra, and please start. And the trainees, last 10 minutes, we'll try to answer all your doubts. Please don't feel shy. Better to err here rather than err in exam directly. No question, doubt is silly. That may be the best question. So put your doubts in chat box and Q&A. In the last 10 minutes, both the examiners will open Q&A and chat box and answer as much as possible in the given time. Thank you, and Narendra, over to you.
Thank you, sir. Can I start, sir?
Yes, sure, please.
Yes, sir. My patient, Mr. Yesumurthy, who is 75 years old gentleman, an agricultural worker from Kakinada, presented with chief complaints of irregular bowel habits since 1 month duration, bleeding per rectum since 1 month duration, constipation since 15 days, and abdominal pain and discomfort since 7 days. The patient was apparently all right 1 month back when he noticed a change in his bowel habits.
Can I interrupt you? This is a word of caution. Now you are presenting something online. And for the benefit of all the students, I like to tell you, don't reveal the identity of the patient.
Yes,
because this is something which is very important and have medical legal implications as well. You can present only a male person who is 75 years old. Don't say it like this because it may end up in trouble later on. Please go ahead.
Sir. Yes, sir. So he presented with irregular bowel habits and bleeding per rectum since 1 month, constipation since 15 days, and abdominal pain and discomfort since 7 days, sir. The patient was apparently all right 1 month back when he noticed a change in his bowel habits like increased frequency of stools, loose stools followed by difficulty in passing stools. He also gives history of blood staining the stools more in the initial part of his defecation. And patient used to feel there is incomplete evacuation and pain in the pelvis following defecation, which is crampy in nature, and it is getting relieved on its own, sir. Patient is also telling that during defecation and following defecation, he is having increased frequency of urine and there is dribbling of urine, sir. For the past 15 days, he started developing abdominal discomfort, distension of the abdomen. Since 7 days, patient is having generalized pain in the abdomen, aggravated with eating food, colicky in nature, and not relieved with medications. And this is the reason why he has presented to us, sir. So he takes mixed diet. He eats non-vegetarian. On an average, he takes non-vegetarian food once in a week. He's a smoker with 30 pack years. He's a non-alcoholic. There is no history suggestive of chest pain, dyspnea, hemoptysis, and jaundice. There is no family history of ovarian cancer, endometrial cancer, gastric cancer, or rectal malignancies. He is married. He has 2 children. Both the children are healthy. He is a diabetic and hypertensive and hypothyroid on medications. He underwent spine surgery 10 years back, and he underwent hip replacement 8 years back. He underwent right femoropopliteal bypass 8 years back for some arterial issues on the right leg, and was on clopidogrel since then. So to summarize my history, he is a 75-year-old gentleman presented with altered bowel habits, a difficulty in passing stools, and bleeding per rectum for 1 month duration, and a history of abdominal discomfort and constipation for 7 days duration. So apart from that, He had diabetes and hypertension, and hypothyroid has comorbidities.
Okay. So, Prashant, would you like to add any comments on this history?
Yeah. So what do you have in your mind? Like, anything else that you think you should have taken in a 76-year-old gentleman with a previous history of a femoropopliteal bypass? Like, what do you have in your mind with these symptoms? Narendra, am I audible?
Yes, sir, you are audible, sir.
You're audible.
Sir, maybe since he will be on blood thinners, some hematoma or something like that. So,
No. What is your differential with this symptoms actually? With a bleeding per rectum, and correlate all your symptoms and give us a differential diagnosis, or what are the things that you have in your mind?
sir, when I first initially asked about all the symptoms and all, the first diagnosis which I am thinking is malignant growths are in the colorectum. Any malignant growth in the colorectum?
See, colorectal is a vague topic. So, other way around, what is going to be your diagnosis at this point of time after history? Are you going to say it's colorectum? Are you going to say it's rectum? Or are you going to say it's something else?
So probably rectal, sir. Rectal etiology.
See, other way around, how the symptom of a colonic cancer is different from symptom of a rectal cancer?
For colonic carcinomas, it depends upon the site of the tumor, sir, whether it's a right-sided colonic malignancies or a left-sided colonic malignancies. So if it is a right-sided colonic malignancies, the patient will usually have a melena, and whereas if in a left-sided colonic malignancies,
Melena, what is melena?
so melena is when the hemoglobin mixes with the acid, and
It is acid in proximal colon.
Sir, usually melena is an upper GI symptom.
Yes, so then we have to bring it here.
Sir, sometimes because of the bacterial action and long duration of the blood in the colon.
Narendra, we have to be really careful about uttering things in exam.
Yes,
so, by convention, it is believed that even though it's exceptions, convention is believed that anything which is occurring distal GI tract, it is bleeding PR. It is not surprising. Occasionally, you may get it, but you should be saying it bleeding blood rather than melena. Prasanth, please correct.
So right side colon will have altered blood, whereas left side colonic growth will have a frank blood or a fresh
it's not melena. It's either altered blood or blood.
Altered blood. So, yes.
And all the more you will have symptoms of a mass or symptoms of obstruction.
Yes,
that's the colonic cancer presentation. But rectal cancer has a typical presentation, which will be showing a bit of abnormalities in defecation.
Yes, sir.
Which are the abnormalities in defecation which are named? Because all of it will be asked in the end examination. Can you describe some terminologies and explain rectal cancer symptoms?
So one is tenesmus, sir.
What is tenesmus?
Tenesmus is a feeling of incomplete evacuation. Feeling of incomplete evacuation followed by deep pelvic pains following defecation.
Is it correct? See, these are very important because I think the test for your ability start with the clinical terminologies. So tenesmus, I think, is a question which is asked umpteen number of times in exams, and you have to have correct definitions. So your success in exam will be decided on such basic, simple answers you give, rather than the trial you are going to speak at the end of the presentations. Prasanth, contribute. You are not audible.
Yeah, the symptomatology of rectal cancer, as sir rightly mentioned, is very important and completely different from the colonic cancers. Okay, so tenesmus is something that which is the recurrent inclination It's not about pain or whether it may be or may not be associated with pain. It is a recurrent inclination to actually, go for stools, or that is what is something called as tenesmus. So the symptomatology should be answered clearly. Okay, so what are the other symptoms that you would specifically? So one of them is, so in this patient, if you see, you have told that patient is having abdominal distension, colicky abdominal pain,
Yes, sir.
correct? Yeah, recurrent colicky abdominal pain. So you need to elaborate on that, because you might be looking at an acute abdomen rather than a chronic abdomen.
Yes, sir.
Okay, so you need to elaborate on that, because the entire management changes whether the patient is having an acute. So you're anticipating some sort of an, what are you anticipating when you have these
Obstruction,
symptoms?
sir.
Abdominal distension with colicky abdominal pain.
Obstruction, sir.
Yeah, possibility of an obstruction. Okay,
Yes.
along with the symptoms that, so it's more likely to be of a carcinoma of the rectum with an obstruction. Correct?
Yes, sir.
Yeah. What are the other symptoms, as sir asked, apart from tenesmus? What are the other symptoms that you're likely to have?
The other symptoms will be passage of mucus diarrhea,
Okay.
early morning watery diarrhea sometimes.
Yeah, it's more or less, both of them are more or less similar.
Yes, sir. And
Yeah.
bleeding per rectum. Usually the blood is mixed along with the stools, sir. And some patients say that they pass the tissue material also while passing the.
Okay. Anything else? Anything else?
For lower urinary tract symptoms also sometimes if there is a local
Why do you get
invasion.
lower urinary tract? How can you explain lower urinary tract symptoms?
Sir, if there is a local invasion of the tumor, uh, it irritates the.
It's very unusual to have lower urinary tract symptoms unless and until the entire bladder is infiltrated, or you have the urethra infiltrated, or so it's two advanced cases. Yes, okay. Then anything else? The same thing. Advanced rectal cancer. What are the other symptoms? There can be.
So,
What happens if sphincters get involved?
so there can be fecal incontinence.
They may have they may have incontinence in advanced tumors when sphincters are involved. Okay, so that will give you an indirect sign of the advanced nature of the disease.
Yes, sir.
Yeah. Okay.
Narendra, you mentioned some urinary symptoms. So can you tell what is the implications of these symptoms on this particular patient?
Sir, since the patient, what I thought is since the patient is having lower urinary tract symptoms, the rectal mass has infiltrated the prostate and seminal vesicles and the prostatic urethra, and it is irritating the urethra, and he is having lower urinary tract symptoms. So.
No, it's usually other way around. What happens is, you have to ask the history of the duration of the lower urinary tract symptoms. And it is usually a man who is 75-year-old man. He has his own issues like prostatic enlargement, and that may be causing the urinary tract by all probability. We have not gone to this imaging till now, but by all probability, that should be a long-standing issue, and it may not be diagnostic of rectal cancer, but it has implications. So you should be asking about these things, not to diagnose rectal cancer, not to rule in a prostatic infiltration, but to know this so that you can plan your treatment and decide some changes in the further management. So what is that? Narendra, I'm asking you, what is the implication of this disturbed urinary function on further treatment planning?
But it indicates locally advanced disease, then we have to go for neoadjuvant chemoradiotherapy.
May not be indicated. Maybe that's what I'm suggesting. It may be indicating a long-standing prostatic problem, which is pretty common at 75 years, but it has implication on later on.
Following the treatment, patients usually will have urinary because of the dissection of the pelvic splanchnic nerve. They will have urinary retention and.
So at this point, unless the patient has some fecaluria or something, I don't suspect it is infiltrating into bladder. So I am little more worried. I'll be worried about post-operatively urinary dysfunction, which is going to happen even without these issues. So in this patient, is going to be 100%. But be really careful, and you have to counsel the patient accordingly. Okay, please go ahead. So what is your diagnosis? Is it
But after history, I am thinking it is carcinoma rectum, sir.
fine? Any differential diagnosis?
As of now, no, sir.
Fine. Please go ahead.
So one suggestion, Narendra,
Yes,
I mean carcinoma rectum with possibility of intestinal obstruction or subacute, because he has abdominal distension right now. Okay,
yes,
with colicky abdominal pain. So he's actually, these are his acute presentation, though his symptoms of the other things might have started a little bit long. So though that is very important. At clinical level, you should also have in your mind that with intestinal obstruction. Okay.
yes,
So
sir.
completed, because those are very significant symptoms that are portrayed by the patient here. Okay.
Yes, sir.
Examination.
So the patient is conscious and cooperative. He is ECOG 2. He has a pulse rate of 84 per minute. BP is 140/90 in supine position, measured in right arm. He is clinically pale. There is no icterus, clubbing, cyanosis, no pedal edema, no generalized lymphadenopathy, no supraclavicular lymph node, and no localized bony tenderness. On local examination, on inspection of the abdomen is distended, umbilicus is in the center and it is normal. Skin over the abdomen is normal. There is no localized swelling or asymmetry noted. There is no visible peristalsis or pulsations. Fullness of the flanks was present. Hernial orifices, external genitalia, and renal angles were normal. Sir. On palpation, there is no local rise of temperature, no tenderness, there is no guarding or rigidity, no lumps were palpable. There are no organomegaly or no bowel loops were palpable. Sir. On percussion, resonant nerve was elicited all over the abdomen. Liver span was from 6th intercostal space to right lower costal margin. There is no ascites. On auscultation, bowel sounds were exaggerated. For rectal examination, sir, on inspection of the perianal region, there were no scars, no skin tags, ulcers, openings, or growth. On palpation, there is no tenderness in the perianal area or no induration is present, sir. On parectal examination, anal tone was normal. Sir, I can feel from 12 o'clock to 7 o'clock position a hard fixed growth is felt, which is smooth throughout the palpation, except at few areas, sir, at 12 o'clock position, where I can feel some ulcers can be felt at 12 o'clock position. The upper limit was not felt. The lesion is felt at the external anal sphincter also. And on withdrawing my finger, blood and mucus stain is present while removing, sir. Systemic examination was normal.
So what was the distance from anal valves?
Sir, it is less than 0.5 centimeters, sir.
So is it described somewhere here?
Sir, it is felt at the external anal sphincter itself, sir. The lesion is felt at the external anal sphincter.
No, no. Have you noted down here? I was asking in your anal examination. Distance from anal valves.
No, sir, I have not noted.
How can you miss such an important thing? Because a lot of things are decided on that thing, Because these notes are useful when the examiner counter check you with your finding. Once you are noted down here, then you are safe.
Sir,
Yes, please go.
sir, why I have not noted down is after just palpating, I can just feel the growth at the anal sphincter, sir, external anal sphincter. It is just about to invade the skin. So that's why I didn't.
No, you mentioned that it is going to anal sphincter, it is going to anal canal, or it is going down to anal verge.
Yes.
So basically, you are reading your report itself should help the person to decide, because this is going to be your recording of case file also.
Yes.
So then later on, somebody should be managing the patient, should be knowing what is the distance from anal verge and how and different management based on that is a very, very crucial aspect of examination to know the distance from anal verge.
Yes.
So what you said just now is of grave importance. Unfortunately, it is not mentioned in your recordings.
Yes.
Okay, and one more thing. When I heard it, it is you look like it's kind of smooth mass with a small ulcer. Is it correct?
Yes, sir.
So, which is not very typical of rectal cancer.
Rectum, sir. Yes, sir.
This looks like something which is submucosal or extraluminal with a protruding ulcer at a small part.
Yes, sir.
See, I am not going to challenge you now, but again, when you come up with colonoscopy, I will re-challenge you.
Yes, sir.
No, but
Prasanth.
yeah, Narendra. So,
Yes, sir.
like, your description is something that which is very an unusual presentation of carcinoma rectum, as Dr. Chandramohan sir rightly mentioned.
Yes, sir.
The important points that need to cover. One is the distal. You have already covered about the anal tone. That the sphincter tone is normal. That is fine. The proximal extent cannot be made. The distal extent has to be mentioned in terms of the distance from the anal verge and not whether sphincter is involved or not is what you will say.
Yes,
Okay. And when you say fixed growth, what do you mean by fixed? Which part of it is fixed? Whether it is fixed to the laterally, whether it is fixed posteriorly, or it's completely fixed where you're not able to, because you don't have a circumferential growth. Correct? You have a 12 into 7 or 7 o'clock position growth, or were you able to complete the rectal examination?
So that fixed it from 7 o'clock, from the 12 o'clock to 7 o'clock position, it is fixed, sir.
So fixed to what structure? I mean, what are you anticipating? Fixed to what actually? Fixed to the sacrum, fixed to laterally,
Fixed to the
fixed to
sacrum.
anteriorly.
Fixed to the sacrum and the lateral pelvic wall, sir.
So it's a completely fixed growth there. Okay. Yeah. Okay. Yeah. And that, I mean, you have to be very cautious when you mention. Then one important thing is incomplete is, have you done a proctoscopy in this patient?
Sir, with only one finger is only, I am able to admit only a single finger, sir. The growth is so large. So we have not done any proctoscope, sir.
Yeah, if you have not done, you should mention. Okay, so proctoscopy or a rigid sigmoid in the, okay, you have to mention that particular thing, which is very, very important to mention in proctoscopy, whether you've done or not done. Okay, even if you've not done, you should mention proctoscopy could not be done.
Yes,
it's very important. Okay, so because some tumors you may be able to see the visual extent, upper extent of the tumor, though not palpable using a scope, if
Yes.
you're able to negotiate. If
Yes.
you're not able to negotiate, you have to mention that. It's important.
Yes,
Okay, if not done, why it is not done is also important. Okay,
sir. Yes, sir.
yeah. So at this stage, you have a patient. What's your differential diagnosis at this stage?
Narendra, before
Yes.
Prasanth, 1 minute. So, one thing you have to remember is only this paragraph or this slide is going to be the only positive finding as far as the patient is concerned.
Yes,
So,
sir.
it's very, very important in rectal cancer. Very, very important because this is usually put as a long case, and the candidate's fitness for pass should be decided by this long case. And unless you have to be very, very clear about all the findings in this thing and document it down, like the proctoscopy he mentioned, and make it so crystal clear that after that there won't be any confusion about diagnosis. So unfortunately, when we read it, it's the mass also. It's a little confusing. It is a very rare presentation of rectal cancer, it seems, or it is a something else as far as I am concerned, which is predominantly submucosal, and there is no description of why you can't reach the upper part of the mass. Is it because of obstruction, or is it because of the tumor is extending further and further? That we don't know, and there is no mention of anything extra palpable. Could you guess the end status of the patient, end stage of the patient by doing a rectal examination? Is it possible?
Sometimes it is possible if nodes are enlarged. Sometimes it is impossible, sir.
So I think this paragraph should have been a well inclusive of all your findings, all your thought process, all your things pointing towards the diagnosis. So it's very, very crucial in national board examination.
Okay, sir.
So if I were you, I should have mentioned apart from anal tone, I should have mentioned correctly the type of the lesion, why I can't reach void. Is it because it is obstructed? Then anything else is palpable, and so much. So try to be as elaborate as possible because this is only positive finding in this patient.
Okay, sir. I can't reach above because of the mass, sir, not because of the obstruction.
You don't explain by when you ask questions. Everything should be explained then.
Yes,
When you
sir.
describe. That's not asking. I know you know everything, but it is your duty to show that you know everything to the examiners while exam.
Yes, sir.
Thank you. Please go ahead. So Prasanth is asking what is the differential diagnosis?
Yeah.
Diagnosis and
Yes.
differential diagnosis.
Yeah, differential diagnosis, Dr. Narendra. At this, we have a history. Can you just? There's no need to sum up because the slide is put up, and I think, as Dr. Chandramohan sir said, this is the complete slide. Yeah.
Okay.
So,
Sir, what I felt after doing my rectal examination is it's more like a submucosal growth. But even though I just want to keep carcinoma rectum as my first diagnosis, and second diagnosis as something extraluminal like GIST or lymphomas as my other diagnosis.
so how frequently does gastrointestinal stromal tumors present like this?
Very rare. Sir.
Oh, okay. Lymphomas.
Lymphomas is the possibilities which I can think of. Sir.
So lymphomas, how rare? I mean, how common or how rare do you have a anorectal lymphoma presenting with a mass lesion and an ulcer? Is that how the lymphomas present?
No, sir. But it's more like a extra mucosal growth.
So they don't have a presentation like this, symptoms of and you have not mentioned to consider it as your differential diagnosis. You have not spoken about any B symptoms. Correct? Have you, when you had a thing, have you spoken about the B symptoms during your history? Correct. So if you're at the level of examination, for all students, remember, like let us say you have examined and you have a completely differential diagnosis, you should always go back to your history and elicit more history related to that differential diagnosis. And then that has to be a negative or a positive history which you need to. It doesn't mean that once you've taken history, examined, you're not going to go back. No, I should not go back to the history and ask questions again. It is very important. After examination, you will have a lot more questions to ask the patient in the history, okay, which will answer a lot more questions, and all those things have to be mentioned. Otherwise, you cannot keep a differential diagnosis and then say that, no, I've kept a lymphoma, but I'm not bothered about the B symptoms. Okay, remember this. Anything you find a new finding, you elicit more history in that, and then that also has to be presented. Okay, so I don't think you can give a diagnosis of a lymphoma at this stage, and this is not the common. This is probably a reported presentations or of such kind of cases. How do gastrointestinal stromal tumors present? Rectal gastrointestinal stromal tumors, because you have kept that as your second differential diagnosis.
For obstructions.
Most common is obstruction, and they don't, very smooth mass. Okay, ulcerations are very uncommon. Okay, fine. So that's how the gastrointestinal stromal tumors commonly present, rather than such kind of a presentation. So do they present with bleeding and this kind, unless and until they've ulcerated to a larger extent?
No, sir.
Okay, yeah. Fine. I think, Narendra, you should recheck your examination findings is what I would say, because this is a very uncommon presentation of any other differential diagnosis that you can actually think of at this time in an elderly gentleman. Okay, with a rectal growth. So maybe when you present your rectal examination finding, possibly you might be right. Then we really have to really think about differential diagnosis in a big way and keep rectum low down the order.
Yes, sir.
If these are the findings. Okay. Yes, sir.
In certain things, I think it is very acceptable to go with a single diagnosis. For example, if you are carcinoma of the oral tongue, don't try to entertain many DDs like lymphoma and stuff there. And this is another scenario, because if you had correctly done a rectal examination, rectal cancer is a telltale diagnosis without much investigations, and here you should not be confused, and you should be confidently saying that, okay, rectal cancer, this is my finding, and this is rectal cancer. and you need not bring in many DDs as we ask. No, we ask to know whether to check your foundation, but in certain cases you shouldn't bring as many DDs to confuse it. Again, here two things went wrong. On your description of the mass itself was a little confusing, and your DDs are you unable to explain it with sufficient um, backups. That's two things which went wrong. Anyway, we'll go for investigations. So, how do you like to investigate this patient?
Sir, initially on presentation we have done a CT scan for this patient, sir.
Okay.
Can I put that up, sir?
Yes. And other way around, if you are initially there is no presentation, patient came to you with these symptoms. So, what is the order of investigations you will order? You propose?
Sir, the reason why we had done a CT scan is since he is having a obstructive kind of picture.
If there is no obstruction, if there is no obstruction, what investigation you will do first?
Sir, if there is no obstruction, I want to go for a punch biopsy from the lesion, sir. If there is a rectal carcinoma, punch biopsy from the lesion, and blood investigations apart from the routine blood investigation, CEA levels I'll send, sir, and colonoscopy to rule out synchronous lesions, followed by CECT.
In punch biopsy, which are the things you ask? You ask for histopathology only, you ask for something else? Because when I'm asking you this
and MIS testing. Microsatellite instability. MSI testing also, sir.
MSI testing. How do you do MSI testing? No, I don't want to waste time, so I'm just asking you. Do you know the difference between ISC, MSI testing by PCR and NGS?
Yes, sir.
Is it indicated now?
Sir,
so these are important questions. Please refer. Please go ahead. And you said the colonoscopy, biopsy, and CT scan.
Yes, sir.
Is that enough? You do want something more?
Chest X-ray to rule out the lung metastasis.
Anything more? CT scan. Is it you take CT chest or CT chest?
CT abdomen plus pelvis followed by chest X-ray.
Fine. Okay. So. You what about CT chest? You don't want CT chest?
Sir, if it is if the clinical diagnosis is very strongly suggesting of carcinoma rectum, I'll go for MR, sir, rather than a CECT. But
I'm asking chest, CT chest.
Sir, Western guidelines, they are saying CT chest will be the thing, but according to the Indian ICMR, chest X-ray is sufficient to rule out the metastasis.
So, according to you, in all patients of CR rectum, you are not going to do a CT chest. Is it correct?
Yes, sir.
So, why I'm asking you, in this patient only, you described the patient is having locally advanced almost sacral fixity, and so it is. Don't you think it is very important to know rule out metastatic disease in the beginning?
Sometimes the tumor from the inferior rectal vein, they bypass the portal system and goes into the systemic circulation. If there is a locally advanced
you know, it is all the more indication for a CT chest, no?
CT chest.
But you want only CT X-ray chest.
So in locally advanced carcinomas, we have to do a CT chest.
See, basically, I think you have to be very confidently support whatever you say. Otherwise, you cannot keep on changing your positions when we counter check it. This preparation should have been done long back your examination. So if you are going to say CT chest, why? If you are going to say CT chest, CT scan, why? And what pertaining to the particular patient, what will you do? That's also important. You forget about ICMR recommendation or NCCN recommendation, but this particular patient sitting in front of you. So what are we going to do, and when are we going to deviate from the recommended guidelines? That's also important. Prasanth, anything? Please take it up.
No, nothing, sir. Yes, sir. To diagnose lung metastasis in any malignancy across, we know that a CT is much better than a chest X-ray. So guidelines may say, but it has to be case specific. Okay, most of the guidelines routinely recommend a CT of the chest in rectal cancers because of there could be a lung mets even without having a liver met. So, what is the incidence of such a scenario? Is it possible, or it has to be liver mets and then you would screen the chest and rectal cancers?
No, it is possible, sir, in 5 to 10%.
Yeah, in about 5 to 8% of them, you can still have lung mets without having a possibility of a liver metastasis. So, CT chest is mandatory. Okay. So, in this patient, you would want a CT chest because you know you're dealing with the locally advanced cancers as well as okay, and possibly obstruction. And I completely agree that you have to get a first CT scan to rule out because you are interested to know whether there is obstruction or not.
Yes,
Okay,
sir.
so before we go on to the CT scan, what are the things that you would want to look at the CT? You know, what are you interested to look at? What do you want to know from the CT?
Sir, I want to see the tumor per se, whether the site of the tumor, where exactly is it, and whether it is involving the local structures or not, like sacrum, lateral pelvic fascia, and bladder, prostate. Then any lymph nodes are there or not. Then any liver metastasis, whether there is an obstruction or not. If there are any peritoneal deposits are there or not.
Okay, okay.
Yes, sir.
Yeah, fine. So let us, do you want to show the CT scan and describe
Yes.
the CT scan quickly?
Yes, sir.
Yeah, if possible, do that quickly.
Yeah, Narendra, one more question. Am I audible?
Yes, sir. Yes, sir.
Narendra, so again, it's very important that how do you order investigations in a preparation of the patient in staging and workup. So from the scratch, you have clinically examined the patient and diagnosed rectal cancer. And what is the first investigation you do, and what is the next, including all investigations?
So first investigation will be proctoscopy guided biopsy, sir.
Fine.
Yes, sir.
Okay. Then
Then I'll go for a colonoscopy, sir.
now I'm talking about practically managing the patient on inclusive, not only oncologically. This patient, particular patient, came to you. You know you're going to do colonoscopy, CT scan, MRI, everything. And what are the investigations you do in order? You can mention some extra investigations also. All inclusive.
So proctoscopic guided biopsy, then
Ah,
routine blood
okay,
investigations
then what
and
is
CE.
next?
Then CEA also with the blood investigations. And
See,
then
then.
then MRI of the rectum, sir.
Okay.
Abdomen plus pelvis MRI rectum. Then
Before
followed
that,
by
in blood, anything other than CA you check? Yes or no? Please go ahead. Time is running
No,
out.
no, go ahead. Time is running out.
yes, sir.
Eh? Yes or no? No. Okay.
No, sir.
Then you do MRI, then you CT scan. So I'll tell you, suppose the patient has a renal dysfunction.
Yes, sir.
Are you going to do CT scan this patient and make him renal failure?
No, sir. We'll see the creatinine level and
That also has to come in your
yes,
answer.
sir.
I know you know, but it has to come. Before doing a CT scan, the checking renal function is very important.
Yes, sir.
Otherwise, you don't alert it. Okay, please read the CT scan.
So as you scroll through, let us know the findings in the interest of time, Narendra. Okay.
Yes, sir. Yes, sir.
Narendra, it's a CT chest. You said you didn't do CT chest.
Sir, here this patient we had done, sir.
Can you move a little fast? We have only 20 minutes left.
One.
So just mention what do you look in the chest, what do you look in the abdominal cuts.
Sir, in the chest, I want to rule out any parenchymal deposits, sir.
Okay. Are you seeing any?
No, sir.
Then what is next? After chest, seat, lung, what do you do next?
Sir, then I'll see the liver, sir. Is there any metastasis in the liver or not?
Okay.
So there are
If,
no
there are,
metastasis.
if you presume there are no metastasis, what is next?
I'll see if there is any free fluid in the abdomen is there or not. So
Great.
there is no free fluid in the abdomen, and
If no free
I'll see
fluid,
for the peritoneum. Then
yeah,
peritoneum,
peritoneum.
I'll see, sir. Peritoneum, sir.
Yeah.
Here I
Yeah.
can't see any
What next?
peritoneum.
What next? What next?
Sir, then I'll directly go to the. I'll just see the colon follow from ileopolic
No,
junction.
no. There is one more important thing you have to check. Liver, lung, liver, peritoneum, and ascites. What is next? Which is important to rule out metastatic disease.
No, sir. I don't know.
Paratic area.
Retroperitoneum.
Properitoneal nodes, any lymph nodes beyond
Yes.
that's also important. These are the
Yes.
4 common areas of metastasis. Of course, you can also look into adrenal and other areas as well, but these 4 are very important.
Yes, sir.
And in the order of commonness, I will say it's first going to be liver first, peritoneum next, and paratic maybe third. So lung comes last. Have you done an MRI for this patient?
No,
Rectum.
sir. We have not done an MRI for the patient here.
Okay, fine. Narendra, since we have short of time, I think you've covered the
Yes, sir.
CT findings. Okay, so now the CT does it look obstructed? Does the colon look obstructed to you?
No, sir. In the CT, colon doesn't look obstructed, sir.
Yeah, so in the CT, the colon doesn't look obstructed. Okay, come down a little bit.
Sir, in the CT, I can see there is a growth arising from the left lateral wall of the rectum, which is mainly extraluminal and compressing the rectosigmoid junction and the rectum, sir. And the growth is it's more or like a homogeneous enhancement with very few heterogeneous areas is there, sir. And
I don't think it is homogeneous. You can see a lot of contrast enhancement and non-enhanced areas. It's not, at least the arterial cut is not very homogeneous.
yes, sir. So, one second.
Okay, looking at this, what is your diagnosis now? Do you want to
Sir,
still
it is
keep carcinoma rectum as your differential diagnosis?
no, sir.
Okay,
It is extraluminal growth. Actually, I'm not sure of the diagnosis with the
You know what?
CT.
Extraluminal things. Can you have some lot of extraluminal stuff also in rectal cancer? Especially this is not a MRI scan. We are not able to delineate the soft tissues correctly. But lot of big extranodal things, can it come in luminal things? Can it come in rectal cancer also?
Any lymph nodes, if they are
Yes.
very much
Yes.
enlarged, then only we can think of an extra luminal thing. Sir.
That's a possibility here. So do you have a biopsy by the patient?
Yes, sir.
so what
That's
is
a
the
biopsy.
differential diagnosis, Narendra? So after seeing the CT, you no longer think that it is a carcinoma rectum. So what are the differential diagnosis now?
Sir, maybe after seeing the CT, means after discussing with the radiologist, they are of the opinion like it might be a neuroendocrine tumor or a lymphoma.
So how does a neuroendocrine look like? Is hypoenhancing or homogeneous? Hypoenhancing, what
Homogeneous.
does it look like? Huh?
Homogeneous, and it won't be presenting this big sir. Usually,
No. What is the
neuroendocrine tumor.
most important finding of imaging of a neuroendocrine tumor artery face?
Hyper enhancement, sir.
Is it there?
No, sir, it is not there.
Neuroendocrine tumor will be enhancing like arteries.
Yes, sir.
So you will have a very hyper intense in the arterial phase compared to for neuroendocrine tumors. So it's not a differential diagnosis. At least after a good contrast CT in arterial phase is not a differential diagnosis. Can you think of some sarcoma?
Sarcoma arising from a retroperitoneum.
Not retroperitoneal. Yeah, in the pelvis.
Pelvis.
Possible,
yes.
Not possible.
Possible. Sir.
I mean, so neuroendocrine is a less possibility. So what, or I mean, for example, even a gastrointestinal stromal tumor now looks more better feasible option rather than thinking. So because of the CT findings, see it's completely compressing, pushing the rectum to one wall, and you can see a smooth rectal wall all along.
Yes,
yeah. Okay, so an MRI is mandatory at this point. Definitely an MRI is mandatory at this point for further management. Okay, so with the CT, you would be able to give us only this differential diagnosis. So what's the biopsy right now? You've done a biopsy, and what is a biopsy? Yeah, Narendra, tell us the biopsy.
Yes, so the biopsy is showing sections show diffuse infiltrative neoplasm composed of predominantly monotonous population of cells which are moderate in size, round to ovoid, hyperchromatic nuclei with prominent nuclei in some. Cytoplasm is scanty to moderate eosinophilic in nature, so brisk mitosis is noted. So they are suspecting like poorly differentiated carcinoma or non-Hodgkin's lymphoma or melanoma and suggested a IHC. So.
Okay, so what do you want? Like what IHC would you want at this stage?
Sir, to rule out soft tissue sarcomas, cytokeratins, and HMB40.
No. One soft tissues, Narendra. See, you have a morphology.
Yes, sir.
So remember, for students, okay, morphology dictates your IHC and not your clinical thing. So you might have differential diagnosis of many things, but then you have your pathology, which gives you malignant, round blue cell tumors. Basically, these are all round small cell tumors. Okay, so this dictates your immunohistochemistry. So now you have to forget, once you have the morphology, now you are out of your other things. So with this morphology, you're not going to have a differential diagnosis of a sarcoma or any spindle cell tumor for that matter, with whatever description is given here. So your IHC should be based on that. You're not going to do a routine IHC for everything. Yeah, so what are you trying to look at? So it's a poorly differentiated. So when you have a poorly differentiated like this, what are the specific IHC? Fine, to some extent agreed that you want to rule out an epithelial, so cytokeratin is negative. Yeah, then next.
So to mainly round blue cells might be we have to rule out lymphomas. So IHS to rule out lymphomas.
Okay. So what is the IHC panel that you would expect from your pathologist?
CD 20 and CD 45.
Okay. Melanoma also is one of the differential diagnoses according to the pathologist. Is there any specific marker?
HMB 45.
Okay, they would do an HMB 45 as well as the melanin.
Yes, sir. Melanin. Yes, sir.
Yeah, so these are the markers to differentiate or rule out. Okay, the pathology, and once you label it as a non-Hodgkin's lymphoma or a Hodgkin's lymphoma or whatever, once you label it as a lymphoma, then work up. So for I think we have to go by your diagnosis here. Let's say that they've given it to you as a lymphoma. What as a clinician do you think it could be possibility of a melanoma?
No, sir.
Less likely to be a melanoma.
Yes, sir.
Yeah, so more likely to be of a lymphoma. More likely to be of a lymphoma. Let us say that lymphoma. What do you want to do now?
Sir, once after confirming the diagnosis, I just want to repeat the peripheral smear also once with an experienced pathologist to rule out any lymphocyte increase in the lymphocytes are there or not in the peripheral smear. So if it is a lymphoma, then we have to give chemotherapy.
Okay. And then chemotherapy. Okay. What are the indications for surgery? What are the indications for surgery in GI lymphomas?
Sir, after chemotherapy, if there is a residual tumor, anything less than anything around 4 centimeters, then we have to go ahead with surgery. Sir.
In lymphomas, you would go ahead with surgery for residual tumors post chemotherapy.
Usually, lymphomas will respond with chemotherapy well, sir. But if there is a residual lesion producing any bleeding or something like that, then
Okay.
white excision to prove whether it is whether it has responded or not responded.
Okay. So, for the sake of students, so the possible indications for surgery in lymphomas across GI malignancies are either a perforation, bleeding, or obstruction. Okay. Or they might have been incidentally diagnosed foreign resected specimens of an obstruction, an unplanned obstruction, or something like that. Okay, so otherwise they are treated completely medically with chemotherapy. Okay, or depending on whether they're treated. So even got it. So these are, I mean, any residual lesion, you generally don't offer surgery for patients with lymphomas with residual lesion. Yeah, okay. So do you want to give the diagnosis of a rectum and then take it shortly over the next 10 minutes, Dr. Chandramohan sir? Though we have a diagnosis.
Before going to the management, I have a advice for the people who are listening to it. Please remember that rectal cancer, adenocarcinoma, is much commoner than any of these other DDs, and don't get carried by this presentation, because even in this case, I feel that when you once properly worked up by immuno and all, it may turn out to be rectal cancer, and entertaining a possibility of non-Hodgkin's lymphoma, melanoma. Melanoma is of course a possibility, but its the presentation is entirely different. It will never produce a mass as big as this, and it will be having just a small lesion with a big nose or metastasis. That is a presentation of melanoma. And lymphoma can present, but it's a rare thing. It won't be presenting like this. Again, the kind of infiltration around the sacral and the tissues around is not very typical about lymphoma. Lymphoma will be growing more systematically than locally into such gigantic dimensions. So, by all probability, I feel that this is a maybe a little different presentation of adenocarcinoma. That is very important. And whenever you make a diagnosis, don't make rare diagnosis. So, in clinical examination, it should be, even if it is deviating a bit from the usual presentations, you have to stick to the commonest thing in your area. And coming to the presentation, I think now we have to decide if it is rectal cancer, how do you manage, Dr. Narendra?
So let us say that the differentiated carcinoma has turned out to be rectal adenocarcinoma. Okay, you've done some markers. You have CK7, CDX2, and CK20. For the sake, we will not get into the details. For all students, please read the markers that are very, very important to diagnose a colorectal. Now it is rectal cancer. How will you proceed? Quickly.
Since this is a locally advanced tumor T4 and there are lymph nodes there, so I want to go for a neoadjuvant chemo, long course chemotherapy, and assess the response after 8 weeks, and then do a repeat radiological investigation, so to assess the response.
Okay, great. Any other forms of radiotherapy you consider here? Any role for short course?
Sir, here there is, I feel there is no role for short course radiotherapy, sir, because this is a locally advanced region. Long course radiotherapy only has proven that the local recurrence rate will be.
I think only 5 minutes left. We can't discuss too much of things now. And what is your full plan after neoadjuvant long course RT? How do you proceed further?
After long course RT, I'll again do a MRI, sir. If it is operable, then I'll go ahead with surgery, sir.
What operation?
In this case, abdominoperineal resection, sir, APR.
And do you think that if it is status quo after chemo radiation, will you think it is operable?
Sorry, sir, I didn't get it.
No, if it is same, there is no change. The
Yes, sir.
CT you diagnosed the cyclofixity and local advance, so it is same. Will that be operable after your chemo radiation? Or how do you decide whether to operate or not? Or if
Sir,
at all operating, what will you do?
if there is
What are
no,
the expertise?
sir, if there is no response, then I'll go for a definitive. I mean, it's like a palliative capox regimen and do a stoma. So,
No, how do you decide? That's why I'm asking.
fix it to the sacrum and the lateral pelvic wall.
So you
Yes,
can't
sir,
have a problem. Every tumor which is fixed to sacrum is not unresectable. Of course, you have to consider the morbidity, considering the age. But there are certain, if you look at locally advanced rectal cancers, there are certain cancers which you can still go ahead with surgery. Certain cancers you can go with external surgeries. Certain cancers you can go ahead with a palliation only. So could you tell? I'll tell you three scenarios. I don't have much. Yeah, the tumor going to the anteriorly and going to the prostate and infiltrating prostate and bladder, and prostate tumor going laterally and going to the lateral rectal, lateral pelvic wall, and tumor going behind and infiltrating sacrum. So how do you manage all these three?
Sir, anteriorly, if it is coming, then we will manage with anterior exentration, sir.
Yes, excellent. Yeah, anterior you can go anterior acceleration.
And
So lateral wall fixation, lateral wall involvement. How do you do?
lateral wall will be extra levator and APR.
Very difficult. Once it goes to lateral wall, it's inoperable. If it is limited to levator ANA, you can go with extra levator excision. That what the site is being done. Postal is infiltrating. It is going to sacrum. It is distally. You can do limited sacral resection if possible. Prasanth, please correct or anything add.
Yes, but
I'm summing up because no time.
Yes, sir. Yes, sir. So most important is the reassessment, Narendra. You have also an important thing is you would get an MRI done in all patients. Okay, so there is a question on the chat also, so I'm answering to that question too. An MRI is mandatory for reassessment in these group of patients. If you have any T4 lesion, okay, any T4 lesion, a reassessment was always to be done by an MRI. Okay, and Narendra, I will not agree with you that you will treat the patient with palliative with the current evidence of total neoadjuvant chemotherapy, total neoadjuvant treatment. So, what is the concept of TNT?
Total neoadjuvant therapy is like Produce 23 and Rapido. They said that with total neoadjuvant therapy, the tumor response rate is good. So recurrence rate is there is less recurrence rate and there is some survival advantage also.
So that not only Rapido, so you have the OPRA trial also, which has actually looked at rectal cancer preservation, wherein in such a situation where you don't have response, you don't treat these patients with palliative intent. They are still not palliative, so you still have an option of giving chemotherapy and then reassessing these patients. So you should, you're too early to treat a patient with palliative intent. So it's not correct that so you have multiple options to say that and to treat these group of patients. Okay, so it doesn't no longer becomes palliative, and that the response rates are very high with total neoadjuvant. So when you're asked about options of treatment, for the sake of residents, you have a short course RT if it is probably a T3 where it is operable, T3 or an a node positive or an MRF threatened, threatened, not involved. You could go in for a short course RT followed by immediate surgery or delayed surgery. These are the options. You could go in for a long course RT followed by surgery after 4 to 6 weeks. Or you could do a total neoadjuvant. Total neoadjuvant, you have multiple protocols for total neoadjuvant. It can be short course RT followed by chemotherapy. It can be long course RT followed by chemotherapy, or it can be induction chemotherapy followed by long course RT. Okay, so all of these options are different forms of total neoadjuvant chemotherapy, and as of today, the practice is changing towards total neoadjuvant therapy for better outcomes. Okay, so that has to be your different ways, and then you reassess these patients after MRI. Yeah. So this
Yeah,
is in a
I think
nutshell.
I would like to add two more things. Number one, you have to consider the age of the patient as well as it's not the chronological age, physiological age, and to the capacity to withstand treatment and the physical condition before go for more aggressive therapies. As Prashant has rightly pointed out, now there is sky's the limit as far as rectal cancer is concerned. You have TMT is coming in a big way, and even neoadjuvant immunotherapy trials are coming in a big way. So at no point of time we will just palliate a patient if the economic conditions as well as the fitness of the patient is conducive for such prolonged treatment, and this also you have to consider in a significant way. Thank you. There are some more questions about BRAF mutation. Prashant, can you answer that? This indication for BRAF and hypermethylation C rectum in the chat box.
Yeah. Yes, sir. So routine testing, MMR testing is more important in rectal cancers rather than the BRAF. These comes in the metastatic setting. So as of now, MMR testing is mandatory for rectal mutations because of the new magic drug, which is still in trials and has shown one phase 1 study of dostarlimab. So that is one, and wherein in MMR testing. And the other questions is how to identify whether it is enlarged mesorectal lymph node or EMVI on MRI, as both appear hypointense on MRI. It is very the EMVI and lymph nodes are completely different. Okay, so the EMVI and completely different because you can follow the vessel and then categorically say whether it is a lymph node or an EMVI. So you're not going to see one cut and say whether it is an EMVI or an lymph node. So we wanted to discuss these points of MRI too, but unfortunately it was not brought up during the discussion. But during an MRI, it is important to say MRI of the pelvis is mandatory for all rectums. It is mandatory for all rectums. Okay, and the so on MRI, you would want to see the T stage, whether it is a T1, T2, T3. Again, T3 can be further divided into A, B, C, D, or T4, A, B. And then depending on that, you could take a call on the MRI. The other features are EMVI, lymph nodes, the mesorectum, and the other threatened. Okay. Yeah. So then the
Also,
other
there are
question.
questions Q&A also in chat box, and Q&A also some people have put questions.
Yes, sir. So some of the questions I'm just reading out, sir. So restaging after NACTRT, metastatic workup imaging required in all cases or not? So metastatic workup is not required in all cases, only if you have a progressive disease. So that is an indication to do a metastatic workup in cases. Okay, otherwise you routinely don't do metastatic workup in all rectums post neoadjuvant chemoradiotherapy. Or if there is even a stable disease, then you would definitely consider it. Okay, the second question we have already answered. Is there an MRI pelvis for radiological assessment? Definitely yes, there is no doubt. So should we say we should offer total neoadjuvant treatment to our patients? Is it yet the standard of care? Chandramohan sir, you want to take this question, sir?
I think it is very soon becoming a standard of care, especially in young fit patients. I think the beauty of total neoadjuvant chemotherapy is that it reaches its limits beyond what is achieved by the conventional short course and long course radiation. Number one, and it has proven a little advantage in terms of distal metastasis, because it has one thing which is challenging even now after long time is distal metastasis, which is up to 30%. So it has grown significantly by 7% down by the total neoadjuvant chemotherapy. I think by more and more guidelines are accepting it in various situations. It is being used. For example, oligometastasis, the little aggressive disease, it is useful. And another beauty of it is you can pursue a non-operative management. Sometimes the Haber-Gamma protocol has been strengthened by giving neoadjuvant protocol, and some centers have achieved as high as 40% of organ preservation rate after this attempts. So there are many questions. I think one thing we couldn't discuss much is the advantage of MRI. MRI in this index case we use only CT scan, but never use CT scan for rectal cancer patients, because the beauty of MRI is that it can delineate soft tissues well, and there are certain protocols like DWI and ADC which will pinpoint whether it is a fibrosis, post-RT fibrosis or disease, so that you can tailor your surgeries well and you can reduce the gravity of surgery from excentralization to local excision. You can easily cut through the fibrotic areas and save the other organs as well. It's very important.
Okay, so why overall survival has not improved after TNT? So that is a question which trials have to answer. So it's not, there is no scientific reasoning for that. So it's a very difficult question to answer. Distance from annual verge assessment by DRE versus a rigid sigmoidoscopy, which is the best? So the best is always a rigid sigmoidoscopy, which gives you the exact distance, but may not be practical or feasible in all situations. So even a proctoscopy actually is a form of a rigid and which will actually help you, especially when you're planning for low anterior or intersphincteric resections. They're really helpful. So what is the duration between long course RT followed by consolidation chemotherapy if there is no response and planning for TNT? So there is no, these patients are immediately started off on chemotherapy after the, remember for students, the entire plan has to be made in the initial, at the first time of your discussion. So if you're planning for a total neoadjuvant, then the plan is made at the diagnosis. Or let us say that the patient has not responded to long course chemoradiotherapy. At that point of time, you're trying to give consolidated chemotherapy for better response. So if you have decided that you're going to treat this patient with TNT, then you're going to choose the regimen. TNT, as I said, I've got multiple options and you're going to choose the regimen in the beginning. Otherwise, if you say that I will treat this patient with long course radiotherapy, then assessment not responded, and then you start off with chemo. So there is no definite duration. You can start as soon as at the earliest. Okay, then if the lesion is only in the upper rectum, should we treat it like colon? Sir, Chandramohan sir?
Yes, the benefit of radiation goes down significantly as we move higher and higher up. And once it reaches the high upper rectum and sigmoid areas, I think the benefit of radiation is significantly gone down. Then you have two school of thought. If you there are radiation oncologists who believe that it has to be the radiation has to be given, even if the distal margin is coming near that rectum. So, but the benefit goes down. There is no, we can't criticize if somebody does a primary surgery for a rectosigmoid growth or upper rectal cancers. And there are a couple of other questions like indication of short course, long course radiation. And one thing we should be very, very careful about, the short course radiation is not a resource saving modality, and it should be promoted as far as possible, because with the same resource for giving radiation for 4 patients, we can in long course we can treat only 1 patient. So this is very important, and you have to try to use it in your practice. And long course chemoradiation should be used when you think, even now it's a very big tumor and almost inoperable, then don't try short course chemoradiation there. And the beauty of short course radiation is now that with the delay it's getting acceptable. And when you have to limit the radiation because of resource issues and because of metastatic disease also pressing, you need to start the chemotherapy very fast. Then that is another added indication. At least in our practice, we try to give the short course radiation and start on systemic therapy into forms TNT, so that the metastasis is also addressed in a significant way. The issue of doing the short course radiation and immediate surgery, the postoperative morbidity goes up significantly high. So that is one thing we should note. When you do immediate surgery after a short course radiation, postoperative morbidity is high. Prasanth,
yes, sir. So the next, can we answer MSI testing as universal testing? Yes, with the current evidence, you should say that MSI testing should be done, but unfortunately, the possibility or the affordability of the treatment for MSI becomes an issue here. So the questions about metastatic, whether we should do metastatectomy first or primary first, whether we should do hepatic metastatectomy first or primary first before removing the primary. So in a patient with rectal cancer and synchronous liver metastasis, so the treatment plan depends upon the local extent of the tumor and the extent of metastasis and whether the lesion is obstructed or not. So it all depends on these things and some form of, because if the local treatment, so it is a very complex question to answer, because you have multiple scenarios. You have an obstructed rectal cancer and non-obstructed broadly divided into 2. And among the obstructed rectal cancer, you again have an operable primary, operable liver lesion in the same. So again, inoperable, locally advanced and early stage. So the entire modality treatment changes. So if you have a lesion, and if you have a locally like T3 or T4A N1, so you would decide on whether you want to give chemotherapy followed by short course RT followed by chemotherapy, which will take care of both your metastatic lesion as well as your local treatment also, because you need to make sure that you should take care of both the lesions when you have, and these are tricky situations where so you have multiple combinations and permutations, and I think it would be difficult to deal in this short period. Okay, lower rectum with inguinal lymph nodes. Yes, they have to be treated when most commonly they get involved as they reach the anorectum, and inguinal lymph node dissection, neoadjuvant chemoradiotherapy with the portals included, and then take a call on that. So, yes, sir has already answered any clinical condition where short course therapy is preferred over long course chemoradiotherapy or vice versa. Sir has already answered that. Difference in the mechanism of radiation, effect of short course versus mechanism of radiation, effect of short course versus long course. I mean, we didn't get the question clearly. I think probably you want to know how it works. So that is the radiobiology. So there's something called as a biologically equivalent dose. So when you give 5 gray per fraction is not equal to 1 or 2 gray per fraction. Radiologically, upper rectum versus lower descending colon, you will be able to, does it really change the management? Whether you want to, that if it's so high, anyway, radiation is out, so probably you would take a call on that. So it might be challenging sometimes to differentiate between a lower descending versus an upper rectum. Can we consider short course even in the presence of positive? I think you wanted nodes, positive nodes. Sir, you want to take this question? Positive nodes, short course.
Yeah. Yep, I think positive nodes means it's N1 disease. In N1 it can consider, but it is gross N2 disease and T4 disease, T3 impinging on T4. I think better rely on long course. But N1 disease, I think you can go ahead with the short course as well. But please mind you, now the short course with the TNT may be replacing the long course in near future. Things are moving in that direction. So as of now, it is better to go for long course radiation in such scenario when you suspect N2 plus or T3 plus. But otherwise, short course is good enough. Thank you.
Yeah. Thank you, sir. I think we have taken most of the questions. Anything else remaining, sir?
Yeah, there is a last question. Inguinal node responded to NSCRT. I think the practice in most Asian countries where they don't rely much on radiation for a radical inguinal and iliac node dissection. But at least in our scenario, when it responded well and significantly disappeared with no nodes, I think we can perhaps avoid doing dissection in those patients. But persistent nodes remaining after CTRT, we have to operate ilioinguinal dissection as well. And if you don't do the ilioinguinal dissection, please watch the patient carefully for in recurrence ilioinguinal area. Thank you.
Yes, sir. I think we've answered most of the questions. I'm not sure whether we have missed. Yeah, only I think one question is how do you differentiate response versus fibrosis in diffusion weighted images and AWC map? So there are specific values that which you can compare between and then differentiate the fibrosis versus response. But in spite of that, post radiotherapy, it is slightly challenging. But with diffusion weighted images, you will be able to make out the fibrosis versus residual disease. How
so the values will be difficult for the surgeon to remember, but you can remember that when you have a fibrosis and you do ADC, and bit of enhancement will be there, and when you then do DW on that, the tumor will be having more enhancement. So that's how you differentiate by DW and ADC.
Yeah. So I think we've taken all the questions, sir. Yeah, Somshekhar, sir.
Yes, sir. So thank you very much, Dr. Narendra, for the presentation, and thank you very much, Dr. Chandramohan, Dr. Prasanth,
Thank you,
and Professor Dr. Somshekhar for joining, and thank you, trainees and faculty members for joining.
Thank you. Great. Good discussion. Enjoyed.
Yes, enjoy.